Hi, welcome everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center, and I'm the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Rosalie and Sherry Exline Ziegler Fund. And tonight we're going to talk about integrative medicine, but not just about integrative medicine. We're also going to talk about research. And my guest is Dr. Alisa Drapeaux. Dr. Drapeaux is from Waterloo area, yes, and then went to the University of Iowa, got a degree in athletic training and a doctorate in physical therapy, and then went on to graduate school at Drake, where she got her PhD, and she currently serves as the Vice Chair of Health Sciences at Drake and also assistant professor, and kind of lead the clinical research team at Drake, right?
Correct. My goal in this role was really to combine, my background in PT, which was a course in clinical medicine, and of course, the treatment and evaluation of patients, along with evidence-based healthcare. So again, how do we marry the two to make sure that we are serving our patients with the best research, along with the best patient experience?
Yeah. Well, tell us a little bit about yourself. So, what was your claim to fame in high school?
My claim, I was the home run queen. So
Okay.
yeah.
And what position did you play?
I played catcher.
You were catcher
Yes,
and the home run queen.
I
was. Good. And did you have a good senior year?
I did. I was named homecoming queen. Which, I think, I don't know how I won, but I won homecoming queen.
Homecoming queen and home run queen.
Yes.
That's a nice dual,
yeah.
Not
something I share often.
Yeah. Left brain, right brain, a
yes.
little bit of both.
Yeah.
Brain and brawn and beauty and everything. And then did you play sports in college?
I didn't. I had an offer at a smaller school, but chose University of Iowa.
Okay. Mm-hmm. And when did you decide that going into physical therapy was something you wanted to do?
So the, kind of normal story of most healthcare providers, but I was a patient. And so I was injured playing high school sports and dislocated my shoulder and underwent PT and just never turned back. I knew I wanted to get to know patients and rehab them back to their functional goals and get a strong relationship with them by seeing them often. So I went into University of Iowa as pre-PT and never changed.
Okay. And then tell us the training program for a physical therapist, the amount of school to become out. Now, someone who goes into physical therapy now comes out as a doctor of physical therapy, correct?
Correct. And so most programs, and you go to school for about 7 years. So 4 years of undergrad and then 3 years of graduate school, which is where you earn your doctorate of physical therapy. And it transitioned because, again, physical therapists were seeing patients direct access. And so we were able to see patients without a physician's referral. Mm-hmm. So the program changed to a doctoral program to make sure we knew how to differential diagnose from kidney disease versus low back pain, and added pharmacology and other courses to make sure that we could do proper triaging as PTs. And so it was about 100 credit hour program, and most programs are around 3 years.
And then did you work as a physical therapist before going back to school?
I did. And so I worked at a clinic in Minneapolis for a couple years and treating a lot of the cabin lover, population up there. And they would travel every Friday to their cabin on Friday and had a lot of chronic pain. So it was a very challenging initial position as a new grad, and then transferred to Des Moines and worked at an outpatient orthopedic practice and treated a lot of, again, chronic pain, but also a lot of sports medicine injuries and post-op, and a lot of spine and ankle were kind of my specialties.
Okay. And then what was the impetus to go back to school to get a PhD?
So with a clinical doctorate, you know how to treat patients, you know how to evaluate, how to diagnose, but you don't know how to conduct research. And being at Drake University and being in a role of a faculty member, I wanted to expand that knowledge of being able to conduct research, design research, and carry through with studies that I, again, kind of perceived interesting with external collaborators. And so that was my desire, to kind of go back and make sure that I had that type of knowledge, to make sure that I was teaching that to my students and then also implementing it with healthcare.
And you used a phrase at the beginning of our conversation. You used the phrase evidence-based.
Mhm.
Explain what that phrase means and the significance of that phrase when it comes to research.
Sure. So evidence-based in general, back from 20 years ago, we kind of, we learned how to treat various diseases and pathologies, and we kind of thought this was right. And the field of PT, and I think some medicine back then, was very gray. And we did what was best for the patient, but also we kind of followed protocols. And now we are using kind of treatment techniques and diagnostic techniques that have been found to be proven in research. And so we know that there's certain treatment for neck pain that is not effective. And therefore, in the patient care setting, I apply the actual effective treatment and intervention, where in the past, I just kind of followed the general protocol. And now we know and kind of apply what has been shown to be evidence-based, what has been effective, so we know we can get our patients better quicker.
And would you say that the evidence-based means that you do it, you record the results in a series of patients? So you might do 100 patients and then actually evaluate either objectively range of motion or subjectively pain relief. And after doing a particular technique a certain way for a number of patients, that's the evidence, is that these patients that you've treated a certain way have improvement.
Yes, absolutely. And I think there's formal and informal. So I think that, when I treat patients, I do a lot of pre and post. And so I may manipulate their joint or I may correct their alignment. But before I do that, I assess their motion or strength and then determine afterwards if that treatment was effective. And so I feel like that's the informal approach, where, of course, there's studies out there where you can kind of have experiential research where you determine kind of what is most effective and compare that to a control group and kind of get it published. And so it is disseminated to everybody in the population. And so they can use that. So.
Right. And that phrase evidence-based is throughout medicine. And we're encouraged to use techniques and treatments that have been shown to be effective. For many, many years, it was sort of, well, this is the way we did it, and it just becomes standard practice, and nobody ever did a study. And more, especially with in the cancer treatment world, it's all evidence-based now. You can't get a new drug approved without doing a study that shows that taking this drug in addition to the others or instead of the others results in better outcomes. So all of that is evidence-based.
Absolutely.
Yeah.
Yep.
And that evidence-based has spilled over into much of the world, whether it is teaching methods that are evidence-based, and anytime we are interacting, more and more we want to know that what we have done has been verified in the real world and has shown to be beneficial. So we are embarking on a collaboration.
Yes.
So we're going to talk about integrative medicine a bit, but then we're going to talk about some studies that we're going to do to generate evidence to show just how valuable these are. So we're going to talk about integrative medicine. So we've done this before. So at our cancer center, we have 1 year ago created an entire program of integrative medicine. We call it integrative medicine because it's not alternative to cancer treatment. It's integrated into the cancer center. How would you define integrative medicine?
You took the definition out of my mouth too. I think, when I think of integrative, I think of multiple, in your case, therapies and services, that it's not a silo approach. It's not something where that's the only thing that patients do or cancer survivors or living with cancer do, but instead it is with a medicinal potential route of chemo or radiation. And then again, kind of how do we support that patient, for example, with potential multiple services. So part of the full treatment plan, for example, whether it's again, kind of post-cancer or living with cancer, but integrated in their life to improve quality of life.
Yeah. Taking care of cancer patients, a lot of people think, well, it's all about killing cancer cells. And definitely killing cancer cells is a component of cancer care, but it's not just about killing cancer cells. It's about taking care of patients and their families. And the integrative medicine program, and we're going to talk about the various components of that, I would say for the most part, is not about killing cancer cells. It's done along with chemotherapy, surgery, radiation therapy, but brings in a number of services that are primarily designed to help support the patient and improve quality of life while they're getting the more traditional forms of treatment that do kill cancer cells: chemotherapy, radiation therapy, surgery. So the programs that we have brought into play at our cancer center are 5 different touch therapies where a practitioner actually touches patients, and that includes acupuncture, chiropractic care, massage therapy, osteopathic manipulative therapy, and physical therapy, which obviously you're an expert at. But integrative medicine also includes many other counseling services, such as genetic counseling, financial aid counseling, nutritional counseling, mental health counseling for patients, mental health counseling for family members, sexual health counseling, mindfulness-based stress reduction, music therapy, art therapy, pet therapy, and all of those are part of the integrative medicine program. So I would say that there is evidence that all of those things provides benefits to patients, but we want to take it a step further and actually do a study to demonstrate how effective these various forms of treatments are at improving someone's quality of life. What does it mean when we talk about quality of life?
So quality of life is has many components. Quality of life is more than just physical. And so as we talked about the different types of traditional, what people think regarding when you have cancer, you go through chemo or surgery or of course go through radiation. And that is one piece of the kind of survivorship of cancer. And so quality of life is looking at the components of physical well-being. It's looking at emotional well-being, cognitive well-being, functional well-being, and then even social support. And knowing that patients, again, that those are all affected as are going through treatment. And we want to look at all components and thinking as a whole person. Even if we do kill the cancer cells, we know, and research shows that, there's a lot of effects that happen post-treatment. So really capturing that person and figuring out how we can meet those individual needs.
Yes. So how, as a researcher, how does one go about designing a study to create evidence that would show whether we're actually improving quality of life?
Yeah, absolutely. So there's many different components. And of course, I can get in depth about research, which again, many maybe don't want to hear about. But part of designing something that is research-based is really looking at what is the research gap? What are we really trying to figure out? What's our current research show? And what does it not show regarding, again, especially these integrative medicine services? And so finding that research gap and really reading the literature and making sure that, again, the study we want to do is needed. And then the second is designing how do we actually collect this information. And so really looking at kind of what type of questions do we ask, and are those questions valid, or really testing what we want to test. And then gathering information, and the goal is figuring out, kind of getting some demographic information on the actual participant, gender and age, and maybe cancer stage, and then linking it with these questions that look at quality of life. And we want to get baseline information and what's happening before they actually start these services. And then we want to kind of track them and figure out after 6 weeks and after 3 months, have those quality of life indicators changed?
So, one of the steps is to determine what questions you ask the patient, and whether those questions have been validated, like that they really do um, sh- um, give us information that will allow us to determine whether things get better or worse.
Absolutely. And making sure, like you said, that, the questions are at something where it's easily understand and they can answer the questions. And again, that it's been tested and proven that it actually assesses what we want it to assess. And so that's the importance of using something that is validated, but also that it's not, 120 questions where fatigue sets in. And so finding that kind of right survey to kind of implement in your study is also important.
So, whenever we're doing research on human subjects, and there's also a great deal of oversight to make sure that the research is not going to cause any harm. So it's easy to understand if you're going to give someone, this drug XYZ that's just been concocted in a test tube, and we don't know what it does, that we want to make sure that we're not going to cause harm. But we're actually, even in asking patients questions before and after, is considered human research. So, what are some of the safeguards and some of the necessary steps that we have to go through when we're going to create a study looking at quality of life for patients going through integrative medicine?
Yeah. So for any, general study, especially the one that involves human research, is that we have to go through an institutional review board, or what's called IRB. And so at Drake University, we have an IRB. And then, of course, at other healthcare institutions like Mercy has an IRB. And we tell the IRB everything that we're going to do with the participants. And in this case, again, it's not inducing some type of, again, non-FDA approved drug, but instead just, again, surveying these patients or these participants. And so they go through a full review of our study. They look at if there's benefits, if there's risks, making sure that we have all of the information, the general methodology, or kind of how we are going to kind of institute the research or design is clear. And that process sometimes can take 2 to 3 months, sometimes 6 months. And then they finally give us an approval. And part of that is that we have what's called an informed consent document. And that informed consent document is something that every participant gets to read through. And again, gives them the right to ask questions if needed, but also withdraw from the study if they choose that it's causing harm. And then, of course, having kind of full confidentiality of the information, and that all the information is de-identified. And so, again, making sure that there's no HIPAA violations, making sure that there's no harm to the patient. And so we go through that full process before we can even start collecting data.
Yeah. And in this case, all of the programs that we're doing, they don't require IRB. They're not investigational. I mean, the physical therapy, the osteopathic manipulative therapy, the chiropractic care, massage therapy, acupuncture, those have all been approved treatments. The research part is really the asking the patient the questions before they go through the program and after they go through the program. So that's really the research part of what we're doing. And that's the part that required having consent and permission from an institutional review board.
Yes. Yes.
So how are we going to conduct the study, and how did we come up with the questions that we're going to ask and the time intervals that we're going to use to ask the questions after they've completed the program?
Sure. So the process in general is that any type of I'll say patient or participant who comes to the Deming Cancer Center, we will get kind of baseline data. And the baseline data, if they're willing to participate, will complete some questions regarding just, again, kind of cancer type and cancer diagnosis and cancer stage. And then they're going to go through a series of questions related to, at that moment, things related to physical health and cognitive health and emotional health and social support. And they will answer these questions, and we will have them start whatever services that they choose. And around 6 weeks, or kind of that general kind of mark where we anticipate some potential changes, we will kind of collect data on the same quality of life indicators and determine again, the goal, and we'll do the same at 3 months, determine as we're going through some of the kind of review of the data is what changes, potentially looking at what services were these participants involved in, and maybe what categories of quality of life changed. And of course, like any study, once we kind of run the analysis, then it may lead to other studies to really look at what is effective and how is it effective.
So again, the research, we're not looking at control of cancer or survival. Our hypothesis is that patients participating in the integrative medicine program will have an improvement in their quality of life. One of the things that we're going to pay particular attention to is I would say we have two general types of patients that are coming to the center participating in integrative medicine. Some are what we would call cancer survivors that have been through the cancer treatment and are cancer-free, but may have ongoing, lingering physical, psychosocial, emotional, philosophical, spiritual issues related to their cancer. And so we think that these integrated medicine programs will improve quality of life. The other group of patients are patients that are living with cancer, that are living with incurable cancer, that are not done with treatment, but are really on a forever treatment. So they have many of the same issues as a survivor, but they also are dealing with ongoing active side effects of active treatment. So they're a different category of patients. There's evidence that some of these integrative medicine can actually reduce the side effects of the treatment that they're going through. So those patients that are actively receiving treatment are a different category of patients than those that are completely done with treatment and are just experiencing lingering side effects.
Absolutely. And, even too, some research shows that, again, kind of post-treatment, that, again, what they're terming the survivorship period, is that for months on end that you can have symptoms of just cancer-related fatigue. You can have anxiety, depression, and some other, general kind of emotional, potentially, or social support issues. And so there's definitely research out there to support things like acupuncture, for example, art therapy, and then a lot of even just nutritional support and helping to improve kind of those symptoms. Because again, we don't realize that when treatment is done and that we think all of it kind of goes away. And we know that that's not the case. And so knowing that, kind of speaking to both populations, knowing that they both need help maybe in different ways. And again, to be determined regarding that, but we know there's definitely evidence out there that, again, is showing some proof or some kind of effectiveness of these therapies, but also we need to know more.
One thing we talked about it would be great if we could also have a group of patients that, for whatever reason, never referred to us or weren't going through an integrative medicine program, and so that we could see not only how integrative medicine helped those patients that we're serving by looking at their questionnaire before they got the services and after they got the services, but wouldn't it be great if we could somehow pair these patients getting the services with patients that are like them that were never referred for the services? But all the patients that are going to come to our center are going to be given these services. And since they've already been proven to be of benefit, withholding those services certainly did not appear like a very ethical thing to do. Any further discussion about how we discern that?
No, I think, you can take in research term, a control group, which, you could take whether it's in Iowa or other states. And, so many times you can go to your physician or your oncologist and, you lean on them for that emotional and social support and cognitive support. And based on time, potentially they don't have time to maybe deliver on all of those things. And so they may just get the medicinal kind of treatment. And so there's populations out there probably that, just get that and don't get the integrative services. So to pull kind of, I'll say, data from those populations would be easy. And so, I think comparing, that control group with our kind of integrated medicine is something that would be interesting to do. And now these participants are going above and beyond the normal service. And
are there, so one valid way would be to look at other studies that took patients that weren't getting integrated medicine services, and there's sort of this baseline. This is sort of the average. And again, we're using validated questionnaires that other studies have used probably over decades. So there's historical studies where they've looked at, well, this is sort of the average test or questionnaire results on patients at various phases in their cancer journey.
Yes, definitely. And that's, too, I think that's where it kind of comes into the, you take something and you're like, what do we not know? And so kind of going back and circling back to evidence-based healthcare, you want to make sure that what you're offering is effective. And so, yes, going back and saying, how do we look at the study that we're proposing and how it's similar to other studies, but yet we're also looking at something different that has not quite been researched before, with all the different types of services that you offer, that I think that we're going to be able to do a lot of analysis and comparing maybe a certain type of service is most beneficial to the emotional health of an individual. Interesting enough that I did a study with Ferals, which is a kickboxing, of course, kickboxing exercise plan here in town. And so we were really looking at kind of the benefit of this program and kind of looked at quality of life also. And the findings showed that it wasn't the physical changes that these participants in Ferals undertook, but more of the emotional. The number one quality of life indicator that increased after a 12-week program was the emotional support. And so it was not our hypothesis. It's not something that I predicted. And so again, gives a weight to saying, what more can we do to make sure we're supporting that emotional and maybe social support with these group exercise?
So with the Feral study, and again, it was individuals coming in and engaging in a rigorous physical fitness regimen. Did you do lots of objective parameters of strength, weight, body fat, waist circumference, those sorts of things?
We did not with this study. We truly were looking at kind of, again, intervals of baseline and then looking a little bit at post at 10 to 12 weeks of quality of life changes. Okay. And so at this validated survey was like looking at questions more on the subjective portion of what has changed. Do you feel, again, more confident in your body image, things like that. And so those are what was collected, but it was self-reported. And so we did not put in objective data like blood pressure or other BMI into it.
So a very rookie error there. Here I am doing a live interview with my phone on. So sorry about that.
No problem.
What are you most excited about? What excites you about this study?
I think, I like research and kind of geek out about research a little bit too. But I think, being a physical therapist, where most people think that we're physical torturists. And, I will say that I always.
Is that what PT stands for?
And so I have to debunk that myth right away because, in general that I found, because through failure, through clinical practice, that, it is so much more about than the physical aspect of treating a patient. And so through kind of my own experience, I realized that, things like eye contact and really, helping their fear and all these components that I feel like I've now have done over the last 10 years, but I didn't measure. And so I think there's a part of it that, yes, it's research and we are asking, participants to kind of, again, actively, complete the survey, but it fuels the future and it fuels the fact that we want to figure out what is effective, how is it effective? And so then you can look at potentially your services and expand or change because now we have evidence behind it. And so I like it for many reasons, but also for the fact that, again, we are really diving into the full patient and full client and not just the physical aspect.
Mhm. And one of the benefits that comes out of doing evidence-based research, obviously, you've already outlined several. It validates what we're doing. It might guide us as to how to expand programming to provide the benefits to more patients. It might give us guidance on, is there a particular part of either the physical or the psychosocial or the emotional or philosophical or spiritual dimension that we're changing. But the other thing is that once you provide evidence that you are providing benefit, it's those sorts of studies that can then be shown to the insurance companies to say, look at this programming that is being done and how it is improving the health of the participants. And that's one of the first steps of getting insurance companies then to agree to reimburse for services that provide significant benefit.
Yeah, absolutely. And that, I mean, there's a lot of stakeholders, at the end of the day too. And when those stakeholders can be insurance. And so, again, that's where the research can be very beneficial in proving that this reduces primary care physician visits, or this reduces, other kind of maybe healthcare dollars, because now they're getting it kind of in one location and kind of, or again, chronic pain or chronic related fatigue related to cancer, and kind of maybe the medication they need to be on for, again, multiple years, and how that can reduce. So yeah, I mean, from a stakeholder perspective, there's a lot of individuals involved, and insurance is definitely one of them.
Maybe share with us some of the other research projects that you've done here in Des Moines, and some of the surprises that you have found.
Sure. I saw, obviously mentioned the quality of life one with ferals, and kind of, again, being the emotional aspect of it. I love the spine and I love the hip. And so I work with some orthopedic surgeons, and one of the studies we are wrapping up in May is related to stem cell. So to be determined on that, and the efficacy with the hip, and injecting stem cells in the hip. And again, if it changes over 2 years. And so,
so just so we understand, this is taking a patient's own stem cells.
It is.
And then injecting it into the hip joint.
Correct.
And in theory, it's thought that these stem cells have the potential to develop into whatever part of the body is needed, and perhaps a stem cell put in the hip joint could become cartilage or other tissue that could improve hip pain.
Correct.
Or range of motion. Or
so right now we're looking at both pain and function, and then we're also looking at radiographs or x-rays, and looking at joint space, and if that has changed at 12 months post stem cell injection. So again, results are to be determined on that one. Some other studies, I work with another oncologist, and looking a little bit at the patient experience. And so one kind of recent study that was that we presented on was looking at providers or physicians, and if they look at patient satisfaction scores, and do they use that data to change their treatment or their approach. And so found some interesting kind of information regarding looking at that data and potentially ordering more labs to kind of, again, please to the patient based on satisfaction scores, or ordering more diagnostic or x-rays. And so that was kind of an interesting finding. And
what about spending more time in the room with the patient?
So it, again, which is leading us to another potential study of really thinking of, there's a lot of research out there that shows 40 seconds. And so 40 seconds is actually what has been shown to really deliver empathy. And so the provider group had talked about time and how busy they are, and how they don't have time to kind of really deliver on a patient experience or maybe show empathy. And so, again, that was that self-reporting that the physicians did. But again, evidence shows that it takes 40 seconds to really sit down with a patient and again, show empathy and show that you're present. And so that provider perception will lead to further training opportunities. So,
Yeah, so I'm aware of one study, and I might be off a few seconds, but that when a doctor and a patient are in a room together, and the patient begins to speak, on average, the doctor will interrupt the patient within 23 seconds.
Wow.
And that it's all about just the facts, ma'am. We got to get through this, and not no elaboration, no taking time for empathy. It's just kind of tell me what's wrong, and I'll tell you what I'm going to do, and then I'm off to the next patient.
Yeah. And that, it happens probably very frequently, now, and even at Drake, one of the courses I teach is professionalism in healthcare, and trying to help our pre-med and pre-nursing students understand the compassion and empathy that's required. The hard skills are definitely difficult to learn, but also that communication and empathy is so important on outcomes. So that was one of my dissertation was related to how that true patient experience affects clinical outcomes. And so, there's definitely research out there to show that if the provider sits down and looks you in the eye and has that 40 seconds with you, that the overall patient satisfaction skyrockets. And so, one healthcare institution put chairs in every room. And so again, kind of implying that the provider should sit down, uncross their arms, uncross their legs, and have a conversation with that patient for, that time, because that really changes that patient experience.
I had no idea that could happen in 40 seconds. Yeah. I would have guessed a lot longer. It doesn't seem like that's enough time, but you're right. The quality of time together, and I guess that would mean that there's so many providers that aren't even offering 40 seconds.
Yeah.
Which is just a tragedy.
It is.
Because the power we have to provide healing by just being present, it's like, why would you not use that power that you have within yourself to provide healing by just being authentically present?
Yep. And I think that, even in the physical torture or physical therapy world, there was so many patients that I would treat that, they came with maybe some trauma in their past or PTSD. And, I would just sit and listen to them and talk to them, or maybe tell them how they should move when they go home if they had low back pain, and, kind of sit and give them that kind of time. And I would not even touch them, that first session, and because they had to earn my trust. And so again, looking at how did that affect their outcomes? And, again, going back to our conversation 30 minutes ago, is it's more than just the physical component that providers, again, deliver to patients every day. So, yeah.
Well, let's open it up to questions here. So we've got a live studio audience, and we'll entertain questions here. And if you're watching us live streaming right now, we invite you to type in your questions.
Okay, first question that I thought of was, how many questions on the form, because you said 120 is too many, and how many patients will be part of the study? How long will you do the study? Will you have interaction with the patients, or will students have interaction with the patients? How will the data be gathered?
Yeah, no, great question. So thankfully, at the Deming Cancer Center, he has a team that kind of are part of that research team that are going to help a little bit with that, informed consent process. And then again, that initiation of the survey. We also have a Drake health sciences student that is there about 8 hours a week that may be able to help also And so the survey will be collected. And right now we have the first survey is probably a little bit longer because we are requesting some information on, again, some demographic information on gender and cancer type and cancer diagnosis. But the actual questionnaire right now is 26 questions. So again, not too high on the participant fatigue aspect. And then when they take the second survey, which will be most likely emailed to them at that specific 6 weeks after baseline, then they can complete it in their home. And then it'll be just around 28 questions, looking at how many services are they still involved in, and then kind of asking them the same questions related to their quality of life.
And these aren't essay questions.
No.
They're pretty, short.
Yeah, and it's kind of a what we call a Likert scale. So it's kind of a not well, somewhat, very well, kind of a scale of about 6 answers that you can choose and click the bubble.
Other questions?
So our program at the Deming Center, it's for 4 events or 4 visits, right? Are we still there?
Well, so there's a
But
variety
for
of
the-
services, as we mentioned, and so let's just kind of tick those off again. There's the various physical treatments, which are acupuncture, chiropractic care, massage therapy, osteopathic manipulation, and physical therapy. And then there's a number of counseling services as well, from mindfulness-based stress reduction to sexual health counseling, mental health counseling for patients, mental health counseling for family members, music therapy, art therapy, mindfulness-based stress reduction, nutritional counseling, spiritual counseling. So as you pointed out, some of those, there's a finite number of sessions that a patient can have. Never do we sign a patient up for all 20 of those services at once. So patients often, when they're engaged in the integrative medicine program, are going through the process for several weeks, some of which the services are limited. So for example, we would love to provide free massage therapy for everyone all the time, but you can imagine that if everyone had an unlimited number of sessions, we just wouldn't be able to meet the demand. So you're right, some of those sessions, there's a limited number, but with the number of services we have, almost all of the patients are going through the services for a minimum of 6 weeks and some for much longer.
Okay, good. And this is not related there, but what would you recommend for sciatica?
Okay.
How much time do we have?
Several of us in the room suffer from that.
So put on your doctor of physical therapy
Yeah.
hat. What's the best way to treat sciatica?
So, my canned response is that, until I would evaluate it, I don't really know the cause. And so I always say it's like, tell me you have chest pain. And well, yes, like tell me if I have chest pain, I give you Tums. And of course that's not the case, and it's cardiac related. So, but I will say in general, the myth that exists out there is that stretching I'll say hamstrings and the leg muscles can really help sciatica or even prevent injury. And there's really no data on that or evidence to support that. And so if you have existing sciatica, then typically it comes from the low back. A lot of times they, again, think it comes from like the piriformis or a muscle in your bottom, which can be the case, but most of the time we can relate it back to the lumbar spine or the low back. And nerves don't want to be stretched. And so when we have sciatica, we tend to want to stretch our hamstring and stretch it out. And nerves love movement. And so they love movement. They love blood to them. So we want to kind of glide them. And so without knowing the cause, I would say that's one thing, is that you will want to do nerve glides. And there is several videos out there that exist, but sciatica nerve glides more than really overstretching it. And then typically, of course, I will say it goes back to a lot of core stability And that's, again, we focus on those two areas the most.
How about spin class?
Spin class is great. Yeah, that in general. I mean, I would say that if you would have it, you would want to adjust your seat height during spin class, because that changes a little bit of how much you stretch that sciatic nerve. Your foot position on the pedal makes a difference, because if your foot position it makes your hip work harder, which makes your sciatic nerve mad. So adjusting your foot on the pedal. And then also during spin class, changing your low back position. So making sure that you go through kind of a flexed or a pelvic tilt and move your lumbar spine and kind of rock it a little bit and change positions a lot.
Okay, great. Yeah. Other questions?
I was particularly interested in the discussion about the study of duration of treatment.
Mm-hmm.
What about frequency of treatment? Let's say somebody you knew had a broken leg and they went to the osteopath. They went to the doctor and they want to see you back in 2 weeks. Well, why not 1 week? And why not 3 weeks? And
Mm-hmm.
what would the difference be? And does insurance ultimately play the deciding role in this? Because if they wanted to see you more often, as an example, it's not covered.
Yeah.
So.
Yeah, I mean, I will say this is that insurance could be a reason. Obviously, you can say scheduling is a reason, but also thinking it is a fracture has certain types of healing timeframes. And there's many variables with that, because we know our pediatric fractures will heal sometimes in 4 to 6 weeks, where sometimes as we advance in age, we tend to take longer. And so we know that there is definitely, after 1 week, we're not going to really see much changes, and we're not going to see many changes on x-ray or radiographs. And so we wait till that soft callus forms. And so we make sure we schedule that follow-up visit at a time where we can see changes on the x-ray, and that we know that we can evaluate if they need longer with their current treatment protocol.
And I'm just going to make a note that the person who asked that question has a broken leg and is wearing a boot.
See me later.
Yes. And he is not a pediatric patient. Other questions?
I have a question as to, I know that the Des Moines area is not that big of an area, and yet you're doing, quite a bit of research. How much research is there being done throughout, say, the United States? And is there any competing things that you actually get with other researchers and be able to help and to expand this?
I mean, great question. I mean, and so the answer in the United States, I don't have a quantitative or a number, I would say. I mean, there is ongoing research, all the time. And, the team approach of being able to kind of get with experts like Dr. Deming, for example, and knowing that I want to kind of pull in a team and including a massage therapist, and we have other investigators part of this, is the most effective, because again, we all come in at a different specialty. And then my second is that you can't just do any research study. You can't say, I just want to research this because it sounds exciting, because if the research is already done, and again, then there's really what we term as a research gap. And so journals are kind of where we publish it, won't accept it because they know that the research has already been done. So there's always that kind of defines what we want to do. And so we always think, what is our question? What do we want to have answered that has not been answered by research? And looking at the last 3 years. And so that's, I guess, my response.
Yeah, I would also say that, yes, there's lots of collaborative, cooperative group research. So, for example, at our cancer center, we have a grant from the National Cancer Institute to be able to participate in clinical trials that the National Cancer Institute has approved. And their patients can be entered all over the country and sometimes all over the world. So what will happen is a study will be approved. So, for example, early stage lung cancer that is being treated with stereotactic radiation. The study that we're participating in is the standard treatment is stereotactic radiation to treat this lung tumor. The treatment arm under investigation is the same radiation, but add immunotherapy along with the radiation. And the patients who participate would be randomized. They would agree that they would allow a randomization, and they would, if they're randomized to the arm that gets the immunotherapy with the radiation, that's the treatment. The standard arm would be the radiation alone. We know that in order to answer the question, which is better, we need to enroll hundreds of patients, and we need to then follow them through at least 2 or 3 years to determine was one superior to the other. So if I wanted to do that study just at my center, it may take years to enroll enough patients that you would have enough patients that, statistically speaking, you could have a difference that would show that one is superior. So these studies get approved in terms of cancer care by the National Cancer Institute, go through a rigorous approval process, including institutional review boards and many physicians and scientists looking at the study. And then once it's opened, it can anyone that is part of the National Cancer Institute research program can enroll patients. You then have to follow very precisely the treatment that has been prescribed, and patients need to, the data gets looked at, audited, evaluated, in order to make sure that at the end of the day, patients treated at multiple institutions around the country are all treated the same way, either A or B, and that you can then compare the results. So that is very, very common to have studies that have been approved by a larger group like the National Cancer Institute, but then made available for patients to be enrolled by those cancer centers that have demonstrated excellence in care and agree to follow the rules very precisely. So very common that that's what will happen, because you want to get the data collected as quickly as possible. You need to have enough patients, and then you need to follow them enough amount of time for long enough to know that you have can show that one form of treatment is superior to the other. And you're looking not just at the control of the cancer, you're also looking at side effects. So you might end up with one that adding additional treatment had some improvement in control of the cancer, but you might show that the side effects were significantly worse. So almost all studies look at both the outcome from control of the cancer, but also in terms of toxicity. Other questions?
That you picked 6 weeks and 3 months as time frames. Any chance that you could do 6 months and a year or 2 years down the road? Or I know there's lots of people that have therapies that go on for years and years and years.
Yeah, no, absolutely. And I think we were trying to decide on the methodology of it, the study, and what was right and made sense. And being this is kind of the pilot study. And, so we can look at that data at 3 months and maybe we stop collection. But then again, that kind of next phase may be, again, if they're willing to participate, maybe we collect data again at 6 months with these individuals. But then again, we have to look at participant response and fatigue. And so what happens sometimes with studies is that you, again, after completing this 26 to 30 question survey and you get sent to your email, then we have participants drop off, and then we don't get a really robust sample size and what's called effect size. And so our results, again, may not be generalizable to the public because we have only 10 participants. So we kind of have to design it based on all these factors, but absolutely, I think there's multiple longitudinal studies out there. And so that's where I think, that it would be great to be able to get 200, clients or participants at this integrative medicine. And yeah, I think we could follow them. Even if we had a response drop off of 20%, we would still have a robust sample size.
Well, thank you. Thank you, Alisa, for being part of it. Thanks for allowing us to talk about the integrative medicine program. Anyone who's listening who is a cancer survivor or in the midst of treatment and wants to participate in the integrative medicine services, it doesn't affect the cancer treatment that you're already receiving, but you can receive the integrative medicine services at our cancer center. And you can access us at MercyOne.org. Our phone number 358-6606, and we're happy to provide you the integrated medicine services. And then it would be up to you whether you wanted to also participate in the study. And as Dr. Drapeaux pointed out, the study is basically doing questionnaires before you get involved in the integrative medicine, and then partway through and after you've completed the program. So thank you for being part of this. Thanks for helping us generate evidence that will demonstrate, hopefully, how effective the integrative medicine program is in improving quality of life.
Yeah, thank you for the invitation.
Thanks, everyone, for participating. If you know someone that would benefit by watching or listening to this program, beginning tomorrow, it will be available on demand at the Above and Beyond Cancer YouTube channel and at the MercyOne Cancer Center website. Thanks for joining us. Please come again next week. Thanks.